It's a great pleasure and honor to be here, and particularly with Professor Christodoulou. I mean, we shared so many battles for psychosomatic medicine over the years. And what I'd like to do tonight is something that is a little bit different from what is done. I'd like to share with you my journey. What brought me to develop the psychotherapeutic strategy. And I heard that there are also medical students at this meeting, and the journey started when I was, I made the wrong, okay. Started when I was a medical student. A medical student in Italy, and I was spending a summer elective a Strong Memorial Hospital in Rochester, New York. I was assigned to the psychosomatic unit. I was with another medical student from Rochester, and we were called to see a woman. This was a 52-year-old woman, and she had a very severe abdominal pain. The medical workup, I mean, it's 75, let's not forget. The medical workup could not establish any cause. And in those cases and in those years, the patients were going to have explorative surgeries. I mean, there was nothing else. But someone in the staff had some doubts about this patient and the need for the surgery, and a psychosomatic consultation was called. So this other medical student, Sam was his name, and I went and started talking, trying to interview this patient. But she was in a great pain. So we were asking questions, but she barely answered. We were uncomfortable. She was uncomfortable. And at a certain point, we looked at each other and agreed and told the patient, we'll come back with the doctor, a medical student, tonight. The doctor was Dr. George Engel, who came to see the patient. And unlike us, he immediately got collaboration from and attention from the patient. At a certain point, while interviewing the patient, he became interested in a scar she had and asked some information about the scar. And the lady suddenly was kind of brightened up, became vivacious, and then started describing several surgical interventions, what went on, and so on. And Sam and I were looking at each other and saying, well, what's going on here? I mean, she was almost dead this morning, and she's so bright and good spirit. Dr. Engel was inquiring about the life setting, and found out that after a very troubled time this woman had, with a lot of problems, things were going very well. So we couldn't understand. I mean, we had this idea, stressful life, circumstances, but things were going well. So we didn't understand anything of what happened. So when we went out of the room, Dr. Engel explained to us what we had seen, the pain-prone patient. And these are the words from his paper. It is just when life is treated the worst, when circumstances are the hardest, that their physical health is likely to be at its best. And they are free of pain. And paradoxically, when things improve, when success is close, is imminent, then painful symptoms develop. So we were amazed about this, and Sam asked, what can we do for this patient? And Dr. Engel replied, not much. The only thing we can do, I mean, this time this patient will avoid surgery, but who knows what is going to happen next time. And this patient is not suitable for psychotherapy. There is no hope that her symptomatology will improve. And I remember Sam and I were young and really eager to help. So we were very disappointed about this answer. And I remember thinking, maybe one day. 20 years later, I was in Bologna, and so totally different setting. And what I do is that I see patients with affective, psychosomatic symptoms, but generally patients who do not respond to standard treatments. So difficult cases. And I was asked to see this philosophy student, 23-year-old with a very severe obsessive compulsive disorder characterized by obsessions related to their girlfriend. Tom was treated initially with fluvoxamine, and then with, didn't respond, then with clomipramine, with no success. He then underwent cognitive behavioral treatment, but he dropped out of therapy after a few sessions because he felt he was getting worse. And by the way, I knew the therapist, and I knew that he was a very good therapist. So, what are you going to do with this patient? I mean, like, he got the standard treatments, good therapist, good pharmacological treatment, but there was something in my mind. See, those who are clinicians, we have files in our brain, and we associate patients, and it doesn't have anything to do with diseases, with other things. So this student reminded me of the lady of Rochester, and I couldn't really understand why, because there couldn't be two more different people. Then, you see, I have the bad habit, which I didn't lose, of reasoning about things, not just following guidelines and the orders. So I started reflecting about one thing. No response to pharmacotherapy, deterioration with psychotherapy. It's not the same thing. You see, this is a study which was done in the 90s and by these Yale researchers. They reanalyzed the data of a large trial with the use of beta blocker after myocardial infarction, and found something according to subgroups, not according to the average patient. Subgroups characterized by certain cardiovascular characteristics, that it was helpful in a subgroup, ineffective in another, and harmful in a third subgroup. I mean, these were people who were publishing the New England at the top level. They had tremendous problems publishing this paper. And you will discover soon why. A couple of years ago, I asked one of the major experts in psychotherapy research, Michael Lambert, who's the author of a famous handbook, and he put together the data that are collected not in trials sophisticated, but in routine psychotherapy practice settings. Improvement, 35%. No change, more than 50. Deterioration. Not many, but you have the 10%. I mean, by the way, these are the same percentages with psychotropic drugs. And the response to antidepressant, the true response is no more than 35% of cases. So that means that the idea that whatever treatment produces a certain response to everyone is wrong. So I thought cognitive behavioral therapy was producing a deterioration in this patient. Maybe the way the things were suggested to the patients were not the good ones. And you see, this is the classic schema of cognitive therapy. Negative situation, automatic thoughts that are identified in the diary, and distress. So I thought, why if we change things? And we asked the patient to monitor not the negative situations, but the positive situation, the feeling of well-being that are aroused, and then we go into the automatic thoughts that stop the well-being and produce distress. So let's try. And if I don't try with this patient, he's a philosophy student, maybe we'll see what happens. So I told the patient to keep a diary. I mean, it's something which you do with cognitive behavioral therapies. But I said, I'm only interested in the instances of well-being. And his comments was then classical. It will be a blank diary. I never feel well. Not true. When he came back to me, he said, okay, I had some good moments, but they lasted very, very, very little, short, a few minutes only. But yes, they were, and I used the structure, the classic structure, a situation. You see here, late afternoon, I'm at home studying. Laura is his girlfriend, will be coming soon. Happy to see her, and the intensity of well-being. So I said, okay, Tom, now, next time I want you to add a column with what interrupts your moments of well-being. And this is what he brought in the third session, and this is an example. Morning, I'm at home studying, feeling of well-being. I was able to study well for one entire hour. For him, this was a tremendous success because he was not able to study, didn't go to the university, didn't take the exams. And a component of the therapy was also the fact of saying, okay, but you have to try to study, you have to go to the university anyway, and we see what happens. And the interrupting thoughts were, now, after 1 hour, something will happen to spoil your morning, and the obsessions will start. So it's working in a way. Of course, I didn't know what I was doing, really, in the sense that I was inventing something. So I said, well, let's add another column. and observer's interpretation. I mean, this is typical of cognitive behavioral therapy or rational emotive therapy. So you have the situation, afternoon, I'm going to the supermarket. This was a student in the University of Venice. So I feel calm and relaxed. It's a beautiful day in Venice. So you can picture the student walking in Venice, and then the interrupting thoughts. I do not deserve these feelings. I cannot feel good. My life is miserable, and obsessions. And then the student started elaborating the observer's interpretation. It's obvious you feel good. There is nothing special in what you're doing. That's another example. I'm home, studying, working well. And again, the interrupting thought. I'm doing this because I forget my turmoil. There is no turmoil inside, only thoughts. And so he was writing this column, and what was amazing was full of philosophical citations, particularly of Greek philosophers, so Plato, Aristotle, and Kant. But I say, okay, let's stay more concrete. So I understood that it was possible to do this type of monitoring, and we could identify thoughts that otherwise we would have not detected. Then the patient, surprisingly, got well and stayed well for several years. You see, my teacher and mentor, Robert Kellner, there was something that he kept on repeating. If a patient gets well, you should always think that has nothing to do with what you have done or prescribe, just coincidence. You have to demonstrate that what you have done is effective. So I say, okay, it got better, but who knows why? I understood the file in the brain. Some people do not believe that they deserve success or happiness and feel they must pay a price for it. And again, you see how much rooted in Greek culture is this observation. But how are we going to test it? So I developed a protocol of a technique, number of sessions, and the basic issues was self-observation of well-being instead of distress, use of structured diary and homework. So you see the structure of well-being therapy, which is initial sessions, we check up, monitoring episodes of well-being, then intermediate sessions, which you identify, in which you identify thoughts and beliefs that lead to interruption of well-being, and final sessions with discussion and modification of dysfunctional beliefs according to well-being dimensions. But I needed some sort of framework to work in terms of well-being. And the framework came from this fantastic book wrote by Mary Jahoda in '58. This is one of the most important books ever written in psychiatry. And this book was almost lost. I found it in a library in Boston, and I copied the book with a dime. So it was an endless work. I was exhausted. So I put the book for a couple of years on my desk. I said, okay, we have read it. It's a incredible book and about positive mental health. Nothing to do with positive psychology. Okay, let's clarify this well-being therapy and everything has very little to do with positive psychology. We are Mediterranean people. We come from ancient civilization. Positive psychology, forget it. And what's Jahoda's model? She grew up in Vienna at the beginning of past century in a fantastic environment by a cultural viewpoint, but there were three things that were not very good at that time. She was a woman, she was Jewish, and she was a socialist. Miraculously escaped from concentration camp, went to England, went to the States, and developed this model. So it's also important to understand. So there are these dimensions which are going to explain a second, autonomy, environmental mastery, growth. But what she stressed is the balance and integration of psychic forces. So it's not happiness. It's something which is much more complex. And this American psychologist, Carol Leaf, developed a questionnaire for measuring Jahoda's dimension. And we used this structure. Let me give you a few examples. Let's take environmental mastery. You see, in the middle, there is the balance functional level, the sense of mastery and competence in managing the environment, able to create context suitable. And you see, each dimension may have a low level or excessive level. Low level difficulties in managing everyday affairs, feeling unable to change, lacking sense of control. But look here, and here you see the difference with positive psychology. It's not the more the better, because also excessive levels are negative, because the patient in that case is unable to relax, is always looking for challenges. And personal growth, a feeling of continued development, sees herself as growing, expanding. That is what this dimension is about. And low level sense of personal stagnation, lacks of improvement or expansion over time. For instance, in Italy, I see, I don't know why, but many colleagues from psychiatry, psychology, from medicine as patients, and cases of burnout. And really the personal growth is the low personal growth. I mean, we've been doing these things and there is no improvement. But again, excessive levels are as detrimental because they are unable, this patient, to process negative issues. It's always a problem of other people, set unrealistic standards. Purpose in life. I mean, a future to believe in, a sense of life, the meaning of life. That is very important. And again, you may have a low level with loss of meaning of life, but at the same time, excessive level with passions, obsessional rigidity. So again, what we try to see, not only that it's the middle of these dimensions, but that each one of us has a blending of this dimension. And what matters is psychological flexibility. This is another dimension, autonomy. Will not go each dimension, and positive relations with others. So again, exaggerated empathy is always sacrificing his or her needs for others, at the same time low levels. So I thought that this model was pretty interesting and could be applied clinically. But the first question was, if we take a group of patients who have been judged to be remitted on either pharmacotherapy or psychotherapy, patient with mood or anxiety disorders, and you compare them with healthy controls, do they have lower levels of psychological well-being? Yes, in all dimensions. If this was not to be the case, we would have stopped working on this approach, but this was the case. So we design, see, in Italy we don't have much funding. I mean, it's a tremendous struggle to get any little funding. So we can only do small studies. So this was a pilot study, and there were 20 patients who were randomized to well-being therapy or CBT of residual symptoms. And what we saw is that both therapy resulted in a reduction of residual symptoms. Well-being therapy even a little more. Then I was very much in the 90s in the idea of maintaining recovery in patients with mood disorder. So what I did, I designed a sequential treatment model, which is a use of pharmacotherapy in the treatment of the acute episodes and use of psychotherapeutic strategies for the residual symptoms of depression, while antidepressant drugs are tapered and discontinued. The model you can also continue. And the idea was that treatment may be, one type of treatment may be employed to improve symptoms that the other type of treatment, pharmacotherapy, was unable to affect. In those days, I mean 90s, it was very, very difficult to convey the message that patients had the residual symptoms. That yes, there was an improvement, but there were a lot of symptoms that remain. So we designed this study with 40 patients with a recurrent major depressive disorder, successfully treated with antidepressants. And we use a combination of CBT and well-being therapy and clinical management. The therapist was speaking with the patient, like non-specific psychotherapy. And in both groups, antidepressant drugs were tapered and discontinued. And then what we did, which would be very difficult to be done in the States, is a long follow-up. People don't move much in Italy. From Bologna, well, they must migrate to Rimini, not go very far. And during this period, no antidepressant drugs were used. And the well-being therapy was associated with, was more effective than clinical management, but was associated with a lower level of relapse. We can see here the group treated after 6 years, more than half of the patients were still well and drug-free, whereas almost anyone in the control group relapsed. But of course, we weren't sure whether which were the ingredients of these, and we were pleased when our results were replicated by a group in Germany. They use well-being therapy and mindfulness, and an American group who applied the combination of well-being therapy and CBT to pediatric depression. So these results with well-being therapy have been replicated, and there are now another couple of studies, one in Canada and one in Netherlands, where they use some elements of well-being therapy, and they also obtain very good results. By the way, the sequential model of treatment, there was a meta-analysis we published 3 years ago, is associated with a significant reduction of relapse. And no matter what treatment you do, whether mindfulness or well-being therapy or CBT, there is definitely an advantage. But what is the specific role? We found it in this study. We took patients with generalized anxiety disorder, a very common disorder, and we compare 8 sessions of CBT against 4 sessions of CBT followed by 4 sessions of well-being therapy. Why did we do this? Because if well-being therapy is not really bringing anything specific, the 2 groups should be pretty much the same, whereas they weren't. The group with sequential combination did much, much better than the other group. And so these results indicate that it's a specific and effective ingredient. And of course, we wait other studies. An interesting study came from Iran. Well-being therapy has apparently has become pretty popular. Not surprisingly, it's another ancient civilization. And this was done with university students with mild levels of depression, and well-being therapy was even better. Another study we did on cyclothymic disorder. It's a very common disorder. It's something that is very painful to a patient. No one is paying attention to cyclothymic disorder. We did, and we found again that the combination was more of CBT and well-being therapy was more effective. And a 2-year follow-up, we found that most of the patients no longer had cyclothymia. So these are the current indication of well-being therapy, increasing the level of recovery and modulating mood. Of course, we need more studies to be pursued with this method. And there are also other perspectives, treatment resistance, trauma, PTSD, eating disorder. I would like to mention briefly the last one, because it's the one we are working on, discontinuing psychotropic drugs. What is this thing? Okay, 1 out of 6 people in the general population in the States is taking psychotropic drugs. In most of the cases, 90% for long-term use. So we're not talking about the benzodiazepine for a short time, for long-term use. And this is a reality which, in our opinion, psychiatry has not acknowledged properly. You see, we have DSM-5, we will have ICD-11, which are flying classifications. They have a little problem. They cannot be applied to real patients because these classifications are for drug-free patients. I no longer see drug-free patients in my practice. 1 out of 100. They are always taking something. And we have to take this into consideration. And so, you see, and we have devised a protocol. Let me quote another teacher of mine. I was very lucky as a medical student, Bishop Lipowski, and a friend of Professor Christodoulou, a great clinician, and he wrote a fantastic paper in '89, unfortunately published in the Canadian Journal of Psychiatry, and that was not very popular, and was saying, well, that was the psychosomatic view of psychiatry. Psychiatry is moving from being brainless to being mindless. And look at what he wrote, 89. Patients are told that they suffer from a chemical imbalance in the brain that is the cause of their illness, that it needs to be fixed by purely chemical means, that psychotherapy is useless, and that personal efforts and responsibility have no part to play in getting better. He was really seeing the beginning of this. This means that we give the message that what the patient does, self-therapy, doesn't count. And everything relies on the use of psychotropic drugs. And so we're using well-being therapy to overcome the discontinuation of psychotropic drugs and to improve self-therapy. How should well-being therapy be applied? I understand that it's not that easy to be followed at the very beginning. Why? Because we are not mainstream. We don't believe that you have a treatment and that treatment is good to everyone with a specific disorder. The data I showed you at the beginning indicate that it's not true, that there are subgroups. So we don't believe that mindfulness is good for every disorder. It's not. And by the way, the evidence is very, very weak if you look it carefully. But if it is something that you apply to a patient with something that is a therapeutic plan, it may make sense. And most of the patients who are seen in clinical practice have complex and chronic disorders, have a mixture of things. And they use, this is very, very difficult to support these days, should follow clinical reasoning. Clinical reasoning, what we are doing as clinicians, we should think about. And case formulations. So the DSM diagnoses are not sufficient, and we need two other methods. One is staging. Robert Kellner and I introduced the concept of staging in psychiatry back in '93. But staging is part of medicine. Oncological, cardiovascular disorders, they all use these staging methods. And so it's important to differentiate the prodromal, acute, or residual phase. What are we in to determine the use of therapy? You see, for instance, this is the sequential model, and you see initial assessment, pharmacotherapy, the first stage. The second stage, after remission, use different strategies. And what is macroanalysis? It's something that may have different names. This is a Dutch psychologist, Paul Emmelkamp, who introduced this method. It's something very simple, looks very strange, or a relationship between co-occurring syndromes and problems on the basis of where treatment should begin in the first place. This looks complicated, but if we take an example of this woman with a major depressive disorder, loss of interest, very irritable, is having problems in the family, no longer has a social life, depression is severe and mixed with anxiety symptoms. So if we just use the SM, we'll say, okay, major depressive disorder with anxious symptoms. Is this sufficient? Not at all. Yes, there is a major depressive disorder, there is anxiety, but in psychiatry, unfortunately, there was a bad use of comorbidity. In no other field of medicine, comorbidity relates only to diagnosis. In all other fields of medicine, comorbidity are problems, are other aspects. So we have avoidance of social situations, family frictions. They're not diagnoses, but they're important for the patient. And we put them together and we see, okay, what are we going to do first? And let's assume that we use an antidepressant drug. The patient has improved the symptomatology, and then we reassess the patient. And we see that depressive symptoms are no longer there, but the anxiety has become is clearer, is social phobia. She has symptoms of social phobia. And then you see family frictions, but then you see also feelings of being inadequate. So we plan an intervention which involves CBT for social phobia and well-being therapy for interpersonal relationships and environmental mastery. So yes, this is a complex intervention, but that departs from the concept of disease as the primary focus of medical care. In geriatric medicine, they have abandoned the concept of disease. It's no longer tenable. You have a lot of problems that you have to classify. And the clinical decision making is based on the attainment of individual goals and with a biopsychosocial model. And as I said, psychiatric disorders that are encountered today in practice are complex. They have comorbidities, treatments. Patients might have been treated with a number of psychotherapies, psychotropic drugs. And we still believe that one course of treatment will achieve results with this patient population. It's wishful thinking. We are just beginning the work with these patients. Okay, yes, there are also rather simple cases, mostly in general practice, but the cases psychiatry tends to see are generally the toughest. And so we need adequate strategies. So my idea is that it's not that we don't have effective treatments in psychiatry. We have obsolete conceptual models. We don't understand the complexity of the disorders. What we are looking is the fact that in practice, but not in research, and it's not a coincidence because unfortunately most of the psychiatric researchers, and particularly in the States, don't see patients. You put them in an outpatient clinic, they will not survive 1 hour. They have no idea of what is clinical practice. So it's time really to test, apply clinical judgment, the forms of clinical judgment that do not find room in current research, to regain control of our discipline and to stop waiting for the clinical advances in neurosciences that have not taken place in the last 20 years. And the basic message is that it's possible to practice a highly effective psychiatry now. Thank you very much for your attention.